major systems in pediatric nursing, respiratory, and cardiovascular. These are absolutely critical areas because respiratory disorders are among the most common type of birth defect. By the end of this lecture, you should be able to distinguish the anatomical differences between pediatric and adult respiratory and cardiovascular systems, recognize the signs of respiratory distress in infants and children, and discuss the nursing care for conditions ranging from the common cold to life-threatening epiglottitis and congenital heart disease. Let's go through these objectives quickly. We need to define key terms, distinguish infant versus adult respiratory anatomy, compare bed rest for toddlers versus adults, review respiratory distress signs, discuss how sinusitis differs in children, cover nursing care for croup, RSV, and pneumonia, recognize epiglottitis precautions, discuss smoke inhalation, post-tonsillectomy care, allergic rhinitis, asthma management, cystic fibrosis care, bronchopulmonary dysplasia prevention, and SIDS prevention. That's a lot, so let's dive in. Ventilation is the mechanical process of moving air into and out of the lungs. In children, this process is affected by several key factors that differ from adults. First, the intercostal muscles, diaphragm, and ribs infants are diaphragmatic breathers, meaning they rely almost entirely on their diaphragm because their intercostal muscles are not well developed. This is why you see more abdominal movement when an infant breathes. The brain controls ventilation through the medulla and pons, and chemoreceptors in the brainstem and carotid bodies respond to changes in oxygen, carbon dioxide, and pH. In infants, these chemoreceptor responses are immature, which means they have a blunted response to hypoxia and hypercapnia. This is a crucial safety point. Infants can deteriorate rapidly because they don't compensate as effectively as adults do. Ask yourselves, why does this matter clinically? If an infant has a respiratory infection, they tire quickly because they're working so hard to breathe with just their diaphragm, and they don't have the same compensatory mechanisms. They can go from looking okay to respiratory failure very quickly. Allergic rhinitis is inflammation of the nasal mucosa caused by an allergic response. Think of it as hay fever in kids. It's often seasonal, triggered by pollen, mold, or other environmental allergens. It's not life-threatening, but it accounts for many lost school days because children are miserable sneezing, itchy eyes, runny nose. They can't concentrate in class. From a nursing perspective, we want to teach parents about allergen avoidance, proper use of antihistamines, and when to seek further evaluation. It's important to distinguish this from the common cold, which we'll talk about next. Nasopharyngitis, this is the common cold, also called coryza. It's the most common respiratory infection in children. You'll see nasal discharge, irritability, sore throat, cough, and general discomfort. The key nursing teaching point here is that complications can occur: bronchitis, pneumonitis, and ear infections. Young children are particularly prone to otitis media because their eustachian tubes are shorter, wider, and more horizontal than adults, allowing pathogens to travel easily from the nasopharynx to the middle ear. Now, let's distinguish this from allergic rhinitis. With a cold, the child will have a fever, purulent nasal discharge, and reddened mucous membranes. With allergic rhinitis, there is no fever, no purulent discharge, no reddened mucosa, but there is sneezing and itchy, watery eyes. This distinction is important for parents who might think their child keeps getting colds when it's actually allergies. Acute pharyngitis is inflammation of the throat structures. It's most common in children 5 to 10 years old. Viruses are the most common cause overall. However, Haemophilus influenzae is the most common bacterial cause in children younger than 3 years. This is important to remember because H. influenzae can cause serious complications. Symptoms include fever, malaise, dysphagia, anorexia, and in viral cases, you might see conjunctivitis, rhinitis, cough, and hoarseness with gradual onset. Viral pharyngitis usually lasts no longer than 5 days. In children older than 2 years, streptococcal pharyngitis strep throat may present with a high fever of 40 degrees Celsius or 104 degrees Fahrenheit. Bacterial pharyngitis requires antibiotics, viral does not. This is a key teaching point for parents who often want antibiotics for every sore throat. Remember, not all sore throats need antibiotics. Inappropriate antibiotic use contributes to resistance. We need to teach parents when antibiotics are truly indicated. Sinusitis in children is different from adults in several important ways. First, the frontal sinuses aren't even present until around age 8 and aren't fully mature until around age 18. So when we talk about sinusitis in young children, we're primarily talking about the maxillary and ethmoid sinuses. These are the ones most often involved in childhood sinusitis. Another unique pediatric feature, the proximity of the sinus to the tooth roots often results in tooth pain when a sinus infection occurs. Parents might bring a child in thinking they have a dental problem when it's actually sinusitis. Clinically, suspect a sinus infection when an upper respiratory infection lasts longer than 10 days. Unlike viral URIs that resolve, bacterial sinusitis persists. It requires antimicrobial therapy. The key nursing role is recognizing when a cold has become something more and ensuring appropriate follow-up. Croup syndromes are a group of conditions affecting the upper airway. Let's start with congenital laryngeal stridor, also called laryngomalacia. This is due to weakness in the airway walls, a floppy epiglottis, that causes stridor on inspiration. Stridor is that high-pitched musical sound you hear when a child breathes in. The important nursing intervention here is positioning. Symptoms lessen when the infant is placed prone or propped in a side-lying position. This usually clears spontaneously as the child grows and muscles strengthen. Parents need reassurance that this is typically benign and self-limiting. Now, epiglottitis, this is a completely different story. Epiglottitis is swelling of the tissues above the vocal cords, which narrows the airway inlet. It's caused by H. influenzae type B. It's most often seen in children 3 to 6 years old and can occur in any season. The course is rapid, progressive, and life-threatening. This is a pediatric emergency. Critical nursing point: do not attempt to examine the throat of a child with suspected epiglottitis. Do not use a tongue depressor. Do not lay the child flat. These actions can trigger complete airway obstruction. Keep the child in a position of comfort, often sitting up, leaning forward, drooling. Get emergency help immediately. The child needs intubation in a controlled setting, usually the OR. Bronchitis is infection of the bronchi. In children, it's seldom a primary infection. It's usually secondary to a viral URI. It's caused by a variety of microorganisms. The hallmark is an unproductive hacking cough. Nursing care focuses on comfort. Cough suppressants before bedtime can help the child sleep. However, and this is important for a parent teaching, over-the-counter agents such as antihistamines, cough expectorants, and antimicrobial agents are normally not helpful. The FDA actually advises against OTC cough and cold medications in young children because of lack of efficacy and potential for harm. This is a key patient education point. RSV is responsible for 50% of cases of bronchiolitis in infants and young children. It's a big deal. This is one of the most common reasons infants are hospitalized. RSV spreads by direct contact with respiratory secretions. Here's a frightening fact. It survives more than 6 hours on countertops, tissues, and even bars of soap. This means meticulous hand washing and environmental cleaning are essential. The incubation period is approximately 4 days. If a child is hospitalized with RSV, place them in contact isolation precautions. This means gloves and gowns because it's spread by direct contact with secretions. RSV is particularly dangerous in premature infants, infants with chronic lung disease, and those with congenital heart disease. There is a monoclonal antibody, palivizumab, given prophylactically to high-risk infants during RSV season. Know this for clinical practice. Pneumonia is inflammation of the lungs in which the alveoli become filled with exudate, and surfactant may be reduced. Breathing becomes shallow, resulting in decreased oxygenated blood. There are many types classified by causative organism, bacterial, or viral. Here's an important age-related distinction. Group B streptococci is the most common cause in newborns. Chlamydia is the most common cause in infants 3 weeks to 3 months of age. This age-specific etiology is important for treatment decisions. Newborns with pneumonia need immediate attention. This can progress rapidly to sepsis. Nursing care includes monitoring respiratory status, oxygen administration, ensuring adequate hydration, and antibiotic administration if bacterial. Positioning with the head elevated can help with breathing. Smoke inhalation injury may cause carbon monoxide poisoning, which is a critical concept to understand. Carbon monoxide binds to hemoglobin with 200 times greater affinity than oxygen, forming carboxyhemoglobin. This prevents oxygen from combining with hemoglobin, so oxygen cannot be transported to tissues. Smoke inhalation has 3 distinct stages. Stage 1, pulmonary insufficiency. In the first 6 hours, the child may have minimal symptoms initially, which is deceptive. Stage 2, pulmonary edema from 6 to 72 hours. This is when the child can deteriorate rapidly. Stage 3, bronchopneumonia after 72 hours due to damaged airways and impaired clearance. It can lead to atelectasis. Severe exposure can inhibit surfactant secretion and cause hyaline membrane formation, leading to acute respiratory distress syndrome, ARDS. This is the same pathophysiology as RDS in preemies. This slide is critical for clinical practice. Pulse oximetry readings are of little value in carbon monoxide poisoning. Why? Because pulse oximetry cannot distinguish between oxygenated hemoglobin and carboxyhemoglobin. The reading may appear normal even when the patient is severely hypoxic. This is a dangerous trap. Treatment is often symptomatic and includes oxygen administration. High-flow oxygen helps displace CO from hemoglobin. Careful monitoring of intake and output is essential, and frequent assessments of arterial blood gas reports are needed. ABGs will show the true oxygenation status. Remember, normal SpO2 does not rule out carbon monoxide poisoning. Tonsils and adenoids are lymph tissue and part of the body's defense against infection. When they become inflamed, children have difficulty swallowing and breathing, especially at night when adenoid enlargement can cause sleep apnea. Nursing care includes cool mist vaporizer to soothe irritated tissues, saltwater gargles for older children, throat lozenges if age-appropriate. Remember, choking hazards in young children, cool liquid diet, and acetaminophen for pain and fever. Surgical removal is not recommended if younger than 3 years of age. Tonsillectomy is done only if there is persistent airway obstruction or difficulty breathing. Current guidelines have moved away from routine tonsillectomy for recurrent infections. It's reserved for specific indications. Post-tonsillectomy care is crucial. We'll discuss this shortly. Asthma is rarely diagnosed in infancy, but infants have increased susceptibility to respiratory obstruction and dyspnea. Why? Several anatomical reasons: decreased smooth muscle in an infant's airway, less ability to bronchodilate, increased mucus glands in the bronchi, more secretions. Normally narrow lumen of the airway, any swelling causes significant obstruction, lack of muscle elasticity. Airways collapse more easily. Fatigue-prone, overworked, diaphragmatic muscle infants depend on their diaphragm, and it tires quickly. Think about it. A small amount of bronchospasm or mucus in an infant's already narrow airway causes proportionally more obstruction than in an adult. This is why infants with asthma or bronchiolitis can deteriorate so rapidly. Asthma obstruction is most severe during expiration. Why? During expiration, the airways naturally narrow slightly, and in asthma, this narrowing is exaggerated due to bronchospasm and inflammation. The child has to work harder to push air out. During acute episodes, the patient coughs, wheezes, and has difficulty breathing, particularly during expiration. You'll see signs of air hunger, flaring of the nostrils, use of accessory muscles, retractions between ribs, above the clavicles, below the sternum. Orthopnea appears. The child wants to sit up, can't lie flat. Chronic asthma manifestations include allergic shiners, discoloration beneath the eyes from venous congestion, slight eyelid eczema, and mouth breathing. These are signs of chronic nasal congestion and allergic disease. Nursing assessment: listen for wheezing, but remember, silence can be worse than wheezing. If the child is so obstructed that no air is moving, you won't hear wheezing. This is a sign of impending respiratory failure. Status asthmaticus is a medical emergency. This is continued severe respiratory distress that is not responsive to usual drugs, including epinephrine and aminophylline. The child has exhausted their compensatory mechanisms. Management requires ICU admission, supplemental oxygen, IV medications, and frequent vital signs, including pulse oximetry. These children need continuous monitoring. The nurse must be vigilant for signs of respiratory failure, altered mental status, exhaustion, cyanosis, silent chest. Intubation may be necessary. This is not a wait-and-see situation. Status asthmaticus requires immediate aggressive intervention. Cystic fibrosis is a multisystem disease caused by a defective CFTR gene. It affects multiple systems. Respiratory thick, viscid secretions obstruct airways. Chronic infections, bronchiectasis, eventually respiratory failure. Digestive secretions block pancreatic ducts, preventing digestive enzymes from reaching the GI tract. results in poor absorption of food. You'll see bulky, foul-smelling, frothy stools due to undigested fat steatorrhea skin. Loss of electrolytes in sweat causes salty skin. This is why the sweat chloride test is diagnostic reproductive. Secretions decrease sperm motility. Thick cervical mucus can inhibit sperm from reaching fallopian tubes. Most males with CF are infertile. This is a chronic progressive disease. There is no cure, though new modulator therapies are changing the prognosis. Nursing care is focused on managing symptoms and maintaining quality of life. Nursing care for CF is comprehensive and lifelong. Key interventions include oxygen therapy for hypoxemia, antimicrobial therapy for infections. Pseudomonas is a common pathogen. Aerosol therapy to thin secretions, use of inhalers for bronchodilation. Postural drainage chest physiotherapy to mobilize secretions. This is done multiple times daily. Breathing exercises to improve ventilation. Prevention of infection is essential. These children should not be around other CF patients due to cross-infection risk with resistant organisms. They need annual flu vaccines, pneumococcal vaccine, and careful infection control. Oral pancreatic enzyme replacements are given with every meal and snack to help digest and absorb food. The diet should be high in protein and calories. CF patients need 1.5 to 2 times the normal caloric intake because of malabsorption. They also need free access to salt because of increased sodium loss in sweat. General hygiene is important. Pay special attention to the diaper area. Stools are irritating. Frequent position changes help prevent pneumonia. Light clothing prevents overheating, which increases sweat and electrolyte loss. Teeth may be in poor condition due to dietary deficiencies and frequent antibiotic use. Dental care needs attention. Long-term goals include minimizing pulmonary complications, ensuring adequate nutrition, promoting growth and development, and assisting the family to adjust to chronic care required. This is a family-centered approach. The parents and siblings are deeply affected. Support groups and mental health resources are important. Remember, CF is a genetic condition. Parents may feel guilt. Genetic counseling is important for family planning. Bronchopulmonary dysplasia, or BPD, is a chronic lung disease that develops in premature infants who required oxygen and mechanical ventilation. Respiratory distress syndrome in the newborn is the major reason oxygen and ventilators are used. The main cause of RDS is prematurity. The lungs are simply not developed enough. The goal of treatment is to administer only the amount of oxygen required to prevent hypoxia at the minimum ventilator pressures needed. This is a delicate balance. Too little oxygen causes hypoxia and organ damage. Too much oxygen and too much pressure cause lung injury and BPD. Prevention strategies include antenatal steroids, which hasten lung development during preterm labor. Administration of surfactant within 15 minutes of delivery can also be helpful. These interventions have dramatically improved outcomes for preterm infants. Symptoms of chronic respiratory distress in BPD include wheezing, retractions, cyanosis on exertion, use of accessory respiratory muscles, clubbing of the fingers from chronic hypoxia, failure to thrive, and irritability caused by hypoxia. These infants work hard to breathe and burn excessive calories doing so. Nursing care focuses on minimizing oxygen needs, providing adequate nutrition. Often these infants need higher calorie formulas or fortified breast milk and supporting growth while protecting the lungs. Parents need extensive education about home oxygen, monitoring, and when to seek help. SIDS is clinically defined as the sudden, unexpected death of an apparently healthy infant between 2 weeks and 1 year of age. The clinical features remain constant. Death occurs during sleep, and the infant does not cry or make sounds of distress. It's silent. The current understanding is that SIDS is thought to be caused by a brainstem abnormality related to cardiorespiratory control. Contributing factors include overheating, irregular respiratory patterns, and decreased arousal responses. It's not caused by vaccines, and it's not anyone's fault. Prevention is our most important nursing intervention. The Back to Sleep campaign, placing infants on their backs to sleep, has reduced SIDS rates by over 50%. Other prevention measures include firm sleep surface, no soft bedding or toys in the crib, no bed sharing, avoiding overheating, and a smoke-free environment. Parents who have lost a child to SIDS need tremendous support and counseling. They often blame themselves. Our role is to provide compassionate, non-judgmental care and appropriate referrals. Now we transition to the cardiovascular system. Congenital heart disease is the most common birth defect, occurring in approximately 8 of 1,000 births. 50% of these infants show signs or symptoms within the first year of life. This is a major area of pediatric nursing. Our objectives include defining key terms, distinguishing infant versus adult cardiovascular anatomy, listing general signs of congenital heart disease, differentiating between ASD, VSD, PDA, coarctation, and tetralogy of Fallot, discussing nursing goals for acquired heart disease, listing rheumatic fever symptoms, discussing prevention, covering hypertension in childhood, describing heart-healthy guidelines, and recognizing Kawasaki disease. These are the red flags that should make you suspect cardiac pathology in an infant or child: failure to thrive or poor weight gain. Cardiac babies burn calories just breathing. Cyanosis. Pallor indicates poor oxygenation. Visually observed pulsations in the neck veins, sign of increased central venous pressure. Tachypnea. Dyspnea, working hard to compensate irregular pulse rate arrhythmias. Clubbing of fingers, chronic hypoxia, fatigue during feeding or activity, can't sustain effort. Excessive perspiration, especially over the forehead, another sign of cardiac workload. In infants, feeding is exercise. A baby with heart failure may take an ounce, then stop to rest, then take another half ounce, then rest. They may take an hour to feed and still not get enough calories. This is a classic presentation. Congenital heart disease is the most common type of birth defect, occurring in about 8 of 1,000 births. Half of these infants show signs within the first year. Causes include genetic factors, maternal factors such as diabetes or infections, and environmental exposures. Importantly, congenital heart disease is not a problem for the fetus because of the fetal-maternal circulation. The fetus receives oxygenated blood from the placenta, so the heart defects don't matter in utero. At birth, however, the infant's circulatory system must take over and provide the child's own oxygen needs. That's when problems become apparent. The foramen, oval, and ductus arteriosus must close, and the lungs must take over gas exchange. If there are structural defects, this transition fails. We classify congenital heart defects into 2 main categories: cyanotic and acyanotic. Cyanotic defects cause deoxygenated blood to enter the systemic circulation, leading to cyanosis. Acyanotic defects do not typically cause cyanosis. Physiologically, defects can be organized into lesions that increase pulmonary blood flow, obstruct blood flow, or decrease pulmonary blood flow. A shunt refers to the flow of blood through an abnormal opening between 2 vessels or chambers of the heart. Remember, blood flows from high pressure to low pressure and takes the path of least resistance. Understanding pressure gradients helps you understand shunt direction. Defects that increase pulmonary blood flow allow blood to recirculate through the lungs. Blood returns to the right ventricle and goes back through the lungs before exiting the left ventricle through the aorta. This includes atrial septal defect, ventricular septal defect, and patent ductus arteriosus. Because oxygenated blood is recirculating to the lungs, cyanosis is rare. These are acyanotic defects. The problem is volume overload to the lungs and left heart, which can lead to heart failure and pulmonary hypertension over time. Think of it this way: the left side of the heart is pumping blood that already went through the lungs back to the lungs again. It's inefficient and eventually overloads the system. Here you see a diagram of the heart with a left to right ventricular shunt. Restrictive defects involve some form of stenosis, narrowing of a vessel. Coarctation of the aorta is the classic example. It's a narrowing or constriction of the aortic arch or descending aorta. Hemodynamically, there's increased pressure proximal to the defect before the narrowing and decreased pressure distally. This means higher blood pressure in the arms and head, lower blood pressure in the legs. You might feel weak or delayed femoral pulses compared to brachial pulses. Blood pressure in the arms will be higher than in the legs. This is a key diagnostic finding. Nursing assessment includes checking 4 extremity blood pressures. A significant difference between upper and lower extremities suggests coarctation. These defects occur when a congenital heart anomaly allows unoxygenated blood to enter the aorta and general circulation. Cyanosis caused by unoxygenated blood in the systemic circulation is the characteristic feature. These are cyanotic defects. Tetralogy of Fallot is the classic example. The child has blue spells or hypoxic episodes because not enough blood is getting to the lungs to be oxygenated. These children learn to squat. This increases systemic vascular resistance, which reduces right-to-left shunting and improves oxygenation. It's a self-discovered compensation mechanism. Tetralogy of Fallot has 4 defects, hence tetralogy. Stenosis or narrowing of the pulmonary artery decreases blood flow to the lungs, hypertrophy of the right ventricle. It enlarges because it must work harder to pump blood through the narrow pulmonary artery. Dextroposition of the aorta is displaced to the right and receives blood from both ventricles, mixing oxygenated and unoxygenated, blood ventricular septal defect, a hole between the ventricles. This is the most common cyanotic congenital heart defect. These children have chronic cyanosis and are prone to TET spells. TET spells occur during the first 2 years of life. They involve spontaneous cyanosis, respiratory distress, weakness, and syncope. They can last up to a few hours and are followed by lethargy and sleep. These are terrifying for parents. The critical nursing intervention: place the child in the knee-chest position. This increases systemic vascular resistance, which reduces the right-to-left shunt and forces more blood into the pulmonary artery. It improves oxygenation. Some children instinctively squat, which has the same physiologic effect. During a TET spell, calm the child, provide oxygen, and place them in knee-chest position. If the spell doesn't resolve, emergency medical intervention is needed. Morphine may be used to reduce crying and hyperpnea, which worsens the spell. Hypoplastic left heart syndrome is a severe defect involving underdevelopment of the left side of the heart. Usually there's an absent or non-functional left ventricle and hypoplasia of the ascending aorta. This can be diagnosed before birth, and the infant is placed on a heart transplant list early. Initial survival depends on a patent foramen ovale and ductus arteriosus to provide a pathway for oxygenated blood to the body. This is why prostaglandin E1 is given immediately after birth to keep the ductus arteriosus open. Without it, the infant will die. Symptoms include grayish-blue color of skin and mucous membranes, signs of CHF, dyspnea, weak pulses, and cardiac murmur. These infants need immediate transfer to a cardiac center. Surgical management involves a series of 3 operations: the Norwood procedure shortly after birth, the Glenn procedure at 4, 6 months, and the Fontan procedure at 2, 4 years. This is palliative, not curative. Transplant remains the only definitive treatment. Assorted medical and surgical treatments are available for congenital heart disease. After any cardiac procedure, nursing care involves monitoring vital signs, closely heart rate, blood pressure, respiratory rate, oxygen saturation, observing for thrombosis formation, especially after catheterization or with prosthetic materials, performing neurovascular checks of the limb if femoral access was used, providing emotional support to the child and family. This is terrifying for parents. The post-operative cardiac patient requires intensive specialized nursing care. Know your baseline, know what's expected, and recognize deviations immediately. Parent teaching is extensive for children with congenital heart disease. Key points include: children should avoid competitive sports because the pressure to win can override the child's need to stop if symptoms arise. Non-competitive, self-paced activities are better nutritional guidance, aims to prevent anemia and promote optimal growth. These children need adequate iron and calories. Vacations to high altitudes or very cold environments may cause adverse responses in a child who is already hypoxic or has cardiac problems. The reduced oxygen at altitude is dangerous. Parents need to know the signs of deterioration: increased cyanosis, difficulty feeding, decreased activity, rapid breathing. They need a clear plan for when to seek emergency care. Acquired heart disease occurs after birth. It may be a complication of congenital heart disease or a response to respiratory infection, sepsis, hypertension, or severe anemia. Heart failure is a decrease in cardiac output necessary to meet the metabolic needs of the body. In children, heart failure often presents differently than in adults. Instead of peripheral edema, you see poor feeding, diaphoresis, irritability, and poor growth. The presentation is more subtle. CHF manifestations depend on which side of the heart is affected. The right side moves unoxygenated blood to the pulmonary circulation. Right-sided failure results in backup of blood in the systemic venous system: hepatomegaly, splenomegaly, peripheral edema, ascites. The left side moves oxygenated blood to the systemic circulation. Left-sided failure results in backup into the lungs' pulmonary edema, tachypnea, cough, wheezing, crackles. In infants, this presents as rapid breathing, poor feeding, and diaphoresis. Most pediatric heart failure involves both sides eventually, but understanding the primary problem helps guide assessment. The goals of CHF treatment are reduce the work of the heart medications like digoxin and ACE inhibitors, improve respiration oxygen, positioning, treating pulmonary edema, maintain proper nutrition high-calorie feedings, possibly NG or G-tube feedings, prevent infection, prophylactic antibiotics for certain defects, flu vaccines, reduce the anxiety of the patient calm environment, comfort measures, support and instruct the parents. They are the primary caregivers and need to understand the condition. These goals are interdisciplinary. Nurses, doctors, dietitians, social workers, and pharmacists all play roles. Specific nursing interventions for CHF in infants. Organize care so the infant is not unnecessarily disturbed. Cluster care, minimize stimulation. Feed early if crying and late if a sleep timing matters. A crying infant uses more oxygen. Feedings are small and frequent. Large volumes overwhelm the heart. These infants may need 24-calorie or higher formula to get enough calories in smaller volumes. Oxygen is administered to relieve dyspnea. Medications are given as prescribed after dosages are checked for safety. Digoxin requires careful dosing and monitoring. Accurate recording of intake and output is essential. Fluid balance is critical. What methods can be used to reduce anxiety in a child? Use age-appropriate language, explain procedures simply, honestly, and without overwhelming detail. Active listening, validate feelings, "I can see you're scared," rather than dismissing them. Offer choices when possible. Do you want the bandage with dinosaurs or stars? Gives controls there, be truthful, never promise it won't hurt if it might. Instead say, it will feel like a quick pinch and then it's over. Presence and trust encourage parental presence during procedures. When appropriate, maintain consistent caregivers to build familiarity. Use therapeutic play, dolls, puppets, or medical play kits to rehearse and normalize experiences. Rheumatic fever is a systemic disease involving the joints, heart, central nervous system, skin, and subcutaneous tissues. It belongs to a group of disorders known as collagen diseases, characterized by destruction of connective tissue. The hallmark cardiac manifestation is scarring of the mitral valve. Peak incidence is 5 to 15 years of age, more prevalent in winter and spring. It's an autoimmune disease occurring as a complication of untreated group A beta hemolytic streptococcus infection of the throat. This is why we treat strep throat with antibiotics to prevent rheumatic fever. The key teaching point: a sore throat in a child should not be ignored. Proper diagnosis and treatment of streptococcal pharyngitis prevents this potentially devastating complication. For diagnosis, you need evidence of preceding streptococcal infection, PELUS, either 2 major criteria and 1 major and 2 minor criteria. Nursing care organized to prevent tiring the patient. Special attention to skin and back care, good oral hygiene, and small frequent feedings. If dental therapy is needed, prophylactic antimicrobial treatment is required before the procedure because of the risk of bacterial endocarditis from the damaged valves. Hypertension is more prevalent during childhood and adolescence than many people realize. Significant HTN is considered when measurements are persistently at or above the 95th percentile for the patient's age and sex. This is why we use pediatric-specific blood pressure charts. We don't use adult cutoffs. Primary or essential hypertension implies no known underlying disease. When the cause can be explained by a disease process, it's secondary. Causes of secondary hypertension include renal disease, congenital vascular abnormalities, and endocrine disorders. In children, secondary hypertension is more common than primary, especially in younger children. Nursing assessment includes accurate blood pressure measurement using the correct cuff size. A cuff that's too small will give a falsely high reading. The bladder should cover 80% of the arm circumference. Treatment and nursing care involve nutritional counseling, reducing sodium intake, maintaining healthy diet, weight reduction if overweight. Obesity is a major contributor to pediatric hypertension. Age-appropriate aerobic exercise program. Regular physical activity helps control blood pressure. Adolescents should be counseled about the adverse effects of drugs, alcohol, and tobacco on blood pressure. For secondary HTN, focus on the underlying disease. Lifestyle modification is the first line of treatment. Medications are added if lifestyle changes are insufficient. The nurse plays a key role in education and monitoring. Hyperlipidemia refers to excess lipids in the blood. Lipoproteins include low-density lipoproteins, LDL, contain low triglycerides, high cholesterol, some protein. LDL carries cholesterol to cells. High LDL is bad cholesterol. High-density lipoproteins, HDL, contain low triglycerides, little cholesterol, high protein. HDL carries cholesterol to the liver for excretion. High HDL is good cholesterol. Pediatric hyperlipidemia is increasingly recognized as a risk factor for early cardiovascular disease. Children with a family history of premature heart disease, obesity, diabetes, or hypertension should be screened. Dietary modification and increased physical activity are first-line interventions. Heart-healthy guidelines for children include balanced diet with fruits and vegetables, whole grains, lean proteins, limited saturated and trans fats, limited added sugars, and regular physical activity. These habits start in childhood. Kawasaki disease is an acute vasculitis of unknown cause, primarily affecting children under 5 years. It's the leading cause of acquired heart disease in children in developed countries. Recognition is critical because untreated, it can cause coronary artery aneurysms. Manifestations include abrupt onset with sustained fever as high as 104 degrees Fahrenheit or 40 degrees C that does not respond to antipyretics or antimicrobials. This is a key distinguishing feature. Fever lasts more than 5 days. Conjunctivitis without discharge bilateral, non-exudative fissured lips, strawberry tongue red, swollen with prominent papillae. Inflamed mouth and pharyngeal membranes enlarged, non-tender cervical lymph nodes, usually unilateral greater than 1.5 centimeters. Other features include rash, edema of hands and feet, and desquamation of fingertips later in the illness. The diagnosis is clinical. There's no specific test. Nursing care is symptomatic and supportive. The main treatment is IV immune globulin within 10 days of fever onset, which reduces the risk of coronary artery aneurysms from about 25% to less than 5%. Aspirin is also given for its anti-inflammatory and antiplatelet effects. Important parent teaching: routine immunizations should be postponed for several months after IVIG administration because IVIG is an immunosuppressant. Live vaccines in particular should be delayed. This is a common exam question and an important clinical point. Long-term low-dose aspirin therapy may be prescribed. Compliance can be a problem because the child feels well and parents may not see the need for daily medication. The nurse must emphasize that aspirin is preventing coronary artery damage that may not be apparent until years later. Cardiac monitoring with echocardiograms is needed to detect coronary artery changes. This is a frightening diagnosis for parents, and emotional support is essential.